Birenbaum Roy from Israel. And before we start, I just wish to say a few words. First of all, to apologize for not being there with you. As you all may know, from the 7th of October, our country is in war after a brutal attack by a group of terrorists. And for these reasons, both me and Karina could not leave the country and come and join you there in India. If I may say on a personal level, I would not leave my family alone and travel at this time. Anyway, although difficult, we raise our heads up and we don't give up, and we continue to do what we love to do on a daily basis, and it is taking good care of our patients. And secondly, I would like to personally thank my dear friend, Dr. Prashant, who has been the brilliant architect behind this big and complicated project of this Fetal Brain Society and this wonderful meeting, grouping together really the most brilliant and most important figures from all over the world to a single room to have state-of-the-art discussions regarding the fetal brain. So thank you, my friend, and I hope to see you soon in person. Now, this talk is aimed to discuss about early fetal brain screening and early neurosonography, and we will talk about the guidelines, but also we will talk about what's beyond the guidelines, and I will give you some tips and tricks and anatomy knowledge regarding how can we approach the brain on an during early pregnancy. I will have to say that for the sake of our time frame and to be orderly, this talk will be focused only on the late first trimester. We'll talk about screening and also advanced brain scanning, but only late first trimester. However, I was also asked to talk about the early second trimester and the early neurosonography, and I will touch each and every one of these different aspects of the early neurosonography in my following talks, in the corpus callosum talk, the early midbrain, hindbrain talk, and the germinal matrix talk. And in each and every one of these talks, we will dedicate a specific section to the early neurosonography because there's a lot of things that should be said there. After this short introduction, let's jump into the water of the 11 to 14 weeks screening scan of the brain. And as you all know, recently the ISWOG published the new updated guidelines for the screening examination at the 11-14 weeks. And in terms of head and brain screening, you see that there's a very basic list of minimum requirements for the scan, but I do think that all of you should push for the more detailed list, which I think should be a minimum if you want to do good medicine for your patients. And you can all, I'm sure you all read these guidelines before, and it includes the shape and the calcification of the calvarium, the shape of the calvarium of the cranium, the division of the brain into two different hemispheres with an intervening interhemispheric falls, the choroplexus, the thalami, the brainstem, the cerebellar peduncles, and the aqueduct, and also the intracranial translucency and the cisterna magna. Now, I would like to take this list and elaborate a little bit and go step by step and to give you some highlights and focus on a few different aspects. The first point we should discuss is a little bit technical issue. If you look at the images of this reconstructed calvarium of 12 weeks fetus, you can see that, first of all, the bones, as you all know, are minimally ossified and quite thin, so they provide quite a good acoustic window. However, if you look at the sutures and the fontanelles between them, they are quite wide, which means that even if you're approaching the brain from the lateral approach, this enables you quite a wide acoustic window in order to have a very nice imaging of the brain just by looking from the lateral approach. However, we must emphasize the point of the difference between the transabdominal and the transvaginal ultrasound. The transabdominal axial views from the brain is informative, but it is limited in terms of resolution and detailing, as you can see here, and as you all know from your daily screen when you approach the brain from the lateral view. However, when you check the same fetus during the same gestational age with a high-resolution transvaginal probe, the level of detailing and the resolution is much higher. So whenever you're suspecting any kind of an abnormality, cranial or extracranial abnormality, take your time, perform a transvaginal ultrasound, even if you can approach only from the lateral approach and no sophisticated multiplanar assessment. This should provide you much better detailing with respect only to the transabdominal, even though today we have newer probes and linear probes and all sophisticated tools, but you have to remember that from the physics point of view, the transvaginal will always provide you better level of detailing, even with the new transabdominal probes. Now, I would like to give you some tips and tricks regarding how to manage and how to use efficiently the transvaginal approach. So you all know that when we're using the high frequency probes, which provides you high resolution, we pay a price of penetrance, which means that we don't see very good objects that are far away from the transducer. Furthermore, in many cases, you have between the probe and the region of interest, you have the uterus, you sometimes have the placenta, and also the fetus is not lying in a favorable position. Like in this clip, for example, you see the fetus is lying in oblique fashion, not in a horizontal orientation. The head is far away, and if you're trying to look at the brain, you have also the bony structures of the face. So the bottom line is that in this image, I cannot say almost anything regarding the normality of the brain. However, try to use this approach and try to use this non-favorable angle and ask yourself, what does the fetus is showing us in this approach? And I hope you will all be able to appreciate in the last 2 seconds that you actually, if I freeze the image and I will scroll it slowly, what you are able to see is the alveolar ridge, the anterior part of the palate, the upper lip, and also the secondary palate closed here. So just after this 1 second of looking at this unfavorable position for the brain, you rule out all of the facial malformations that you may have, because you have no cleft lip, no cleft palate, no cleft of the secondary palate, and when you rotate in 90 degrees, you can see the location of the chin, and you rule out also retrognathia, micrognathia, and glossoptosis. So although sometimes we are very frustrated because we are targeted to the brain, stop and take advantage of whatever the fetus is giving you, and then you may continue to improve the position for the head. Now, when you're doing this scan, when I was scanning this fetus, I saw that although I have an obstacle here with the placenta, there's a niche here. On one of the sides, you see that there's a niche, there's an area in which if I was able to get the head closer here to the probe, I will have much better imaging just by manipulating the head a little bit towards this area where the placenta ends. And the same fetus, just a few seconds later, when I manually move the head into this niche here, not niche, this area where the placenta ends, you can see that once I get much closer to the brain, because I'm using a high resolution probe and because I have a short distance between the brain and the probe, I'm getting a very nice image, very good resolution, although I'm just approaching the brain from the axial lateral view. So remember this, and remember that sometimes the fetus, before you start to fight with the fetus for the brain, take advantage of whatever the fetus is giving you. Now, the tip number 2 is the fact that, as I told you before, although we are coming only from the lateral approach in the screening, because we have such a wide acoustic window, we can use that in order to study the brain in a more detailed images beyond only the classical traditional axial views of the brain. So if we start with the traditional axial views, as you can see here in this video clip, and this is the orientation line, but if you just, you don't have to manipulate the fetus, just rotate your probe, rotate the plane of acquisition. Here, you come up with a very nice tilted coronal image, and if you go posteriorly, you have a very nice coronal images of the midbrain, hindbrain, which are located inside the posterior fossa, and we'll go into this in details later on. And the same goes for the anterior part of the brain. If you just rotate the probe and you use the upper part of this acoustic window on the lateral sutures of the skull, you can have a very nice image of the basal ganglia and the ganglionic eminences and how they are separated from the choroid plexus, and we'll also touch a little bit this point later on. But remember that if you're approaching by the transvaginal view from the lateral, just by rotating the probe, you don't have to change to the true coronal or sagittal, and you may obtain very nice images, but please go slowly. Sometimes these are very small structures. Sometimes if you sweep too fast through the brain, you might lose some minor findings. So once we understand that, let's go back to our screening image. You see, I'm showing you how to perform it very, very slowly. You go slowly through the anatomy, and actually, this is the checklist that you have, the working list that you have to bear in your mind and remember that these are all the structures that you should investigate while making this short and slowly sweep through the axial planes of the view. So you need to look at the telencephalon, that has separated into two separate ventricles and hemispheres with an intervening interhemispheric fissure and the third ventricle. You must look and recognize the choroid plexuses. You should be able to study at least some parts of the hemispheric surface and to make sure there are no sulci. The brain should be smooth at this gestational age, obviously. You must be able to see and to distinguish the ganglionic eminences and the basal ganglia, and we will shed a little bit more light on that later on. Then you go to the diencephalon, the two thalami, and then you continue to the mesencephalon, which is the midbrain with the aqueduct and all the components of the midbrain. And then you go a little bit lower, as you can see here, to the cerebellum, and the cerebellum is composed of a midline area and the two hemispheres. And then you have the choroid plexus of the fourth ventricle and the fourth ventricle itself, and eventually the normal physiologic evagination of the Blake's pouch, protruding into the cisterna magna as a physiological finding during late first trimester. Now, let's say a few words about the choroid plexuses, because although it sounds trivial, but sometimes there's some things you need to remember. So what do we know about the choroid plexus? And you can see them here in three orthogonal planes, the axial, the coronal, and the parasagittal plane. So you remember that during early ultrasound, late first trimester, the choroid plexus should occupy almost the entire width and space of the lateral ventricles, as you can see also here on the parasagittal and on the axial views, and also the width occupies the entire width of the lateral ventricle. They extend anteriorly as opposed to what you're used to in the second half of pregnancy. During early pregnancy, the choroid plexus extend anteriorly, which gives rise to this butterfly shape here, as you all know it. You must be able to recognize the choroid plexus crossing and continuing, touching each other, continuing with each other through the foramina of Monro. And remember that cystic structures inside the choroid plexus are very rare in early first trimester. Of course, everything in medicine rare, someone saw sometime or once. However, this is something that you should not see on a daily basis. And if you do find a cystic structure at the area of the choroid plexus, you have to ask yourself, are you sure this is a choroid plexus cyst, or the cystic finding is located in somewhere else? But another important point for you to remember regarding the choroid plexus in early pregnancy is the structure called the choroidal fissure. Now, if you go back to the embryology, you know that the formation of the choroid plexus involves an invagination of the Mannings, which wraps around the vessels, and then these epithelial cells that transform into choroidal cells, and eventually they grow like a flower into the cavity of the lateral ventricles, and leaving behind them a trail of folded Mannings, which is in communication. The vessels are communicating inside and outside of the choroid plexus through this longitudinal fissure, where you have the fold of the choroid plexus and the Mannings along this fissure. And for this reason, because the density of this fold is much higher, with higher echogenicity compared to the surroundings, you must be able to recognize this fine echogenic line at the base of the choroid plexus, and these give you the anatomic borders between the choroid plexus and the surrounding brain. And you can see here this line which corresponds to the infolding here throughout the entire length of the lateral ventricles. Now, why is it important? Because the structures that are close to it or just touching the choroid plexus, but they are completely different structure, are the ganglionic eminences, and we will dedicate a short talk to the ganglionic eminence later on in our course, but you must be able to distinguish between the ganglionic eminence and the choroid plexus. And how do we do that? First of all, they are different in terms of echogenicity, and you look here at this 3D reconstruction at three different planes. So plane number one goes up here through the choroid plexus. You can see both of them here. Plane number two, which is this one, goes through exactly the choroidal fissure. So you see the surrounding hypoechoic, and the hyperechoic line that crosses through the choroidal fissure, marks the borders between the ganglionic eminences here and the beginning of the choroid plexus. And then you go a little bit lower into section number 3, you are completely cutting through the ganglionic eminences, and you can also see them here in this parasagittal reconstruction, and all the way back here is just the tip of the temporal horn of the choroid plexuses. Now, how does it look in the live 2D scan? Again, you look at this, you scroll through the brain by the axial plane view, and you go slowly, and I will stop the image here for you, and I'm going slowly here, and you can also all appreciate this fine line. I'm going back and forth through this echogenic line here, and whatever comes after this line, this more hypoechoic, is not the choroid plexus. These are the ganglionic eminences, and when you go a little bit lower, and you fall into the choroid plexus, and in between them is this fine line of the choroidal fissure, as you can also see here. And remember this, go slowly, and look for the choroidal fissure. Another important fact that you have to remember when you're assessing the early brain at late first trimester is the hemispheres must be smooth. And this is a reconstruction of a volume, but you can do it also on the 2D image. So going from anterior, the anterior pole of the one of the hemispheres, and then you go all the way through the body of the ventricle and the body of the hemisphere, all the way to the occipital horn and the occipital lobe of the hemisphere, and you can see all the way through, everything is completely smooth, and then you go all the way down to the temporal lobe and the temporal horn. And you have to remember that the indentation of the sylvia and the early operculization just starts to appear at this gestational age. So sometimes it's quite difficult to see this very fine indentation here, but this is normal for 12 or 13 gestational weeks. In any case, you should not locate any folds or sulci. If you have a sulci on someplace on the hemispheres at 13 weeks, this is and you are sure this is a sulcation, this is 100% pathological brain. Now, I showed you this tilted angle between the coronal and the axial, as you can see here in the reference line. And when you go through exactly this plane, you come up with this image, which I think is an image that all of you see every day, because it's somewhere in between the coronal and the axial view. But this is a perfect image to see the continuity, or what we call the diencephalic mesencephalic junction, the continuity between the diencephalon and the mesencephalon. So we talked about the ganglionic eminences, you recognize them here, but once you go with your eyes backwards toward the rhombencephalon, you're going through the diencephalon, the two thalami, and this echogenic line is the two thalami touching each other along the closed cavity of the third ventricle. And then you continue in a straight line down into the rhombencephalon, down to the mesencephalon, which is the future midbrain, and this is where the superior cerebellar peduncles will cross. They're coming from the rhombencephalon upward to communicate with higher centers. And you have to remember, bear in your mind this pattern, this image pattern, because you should be able to recognize it and ask yourself, if you find a pathology, to which part of this anatomy it belongs or it evolves from. Now, there's not much more to say about the infratentorial anatomy because it's quite primitive during 12 or 13 gestational weeks, as opposed to what happens after 14 weeks, and we will talk about this later on in other talks. But I would like to focus now on the infratentorial anatomy, or what we call the posterior fossa anatomy, what I prefer to call the midbrain, hindbrain anatomy. And what does this structure is composed of? It is composed of the mesencephalon here, which is a long curved tube-like structure with very thin walls and a large lumen, which is the aqueduct, and the rhombencephalon, the kinked rhombencephalon with its unique flexures. And what are the components of the midbrain, hindbrain in late first trimester? So we have the midbrain, which is this tube-like structure, thin walls and a large aqueduct inside, and this aqueduct leads to the lumen of the rhombencephalon, which is composed of the cerebellum and the vermis posteriorly, or the future vermis, the evolution of the vermis, and anteriorly is the kinking or the flexure of the pons, and straight into the cavity of the fourth ventricle with its choroid plexus. And in between the aqueduct and the fourth ventricle, this is an area called the isthmic area. It's an important area in terms of malformation of midbrain, hindbrain. And another important fact to remember that during late first trimester, the brain is still embryonic in nature, which means that it still has its unique Z-shape appearance, which is the result of these two kinking, the mesencephalic and the pontine flexures, which has not undergone the normal straightening yet. This is a phenomenon that will happen later on, and we will talk about that in one of my talks. Now, how do we assess the posterior fossa or the midbrain hindbrain? So the first approach is the axial screening view, the regular axial screening view, and this is something I'm sure that you've all seen in your daily scans, and we will go into the all different structures here in a few minutes. But as you all know, we've been taught that while we are doing the nuchal translucency, we can also appreciate the posterior fossa structures. However, I would like to point out a little limitation of this approach. And this is an image that was performed, a high quality image performed in a very high quality, high frequency transvaginal probe. So you cannot say that there's a low quality of the image, but the problem is that when you're insonating anteriorly through the face, through the frontal approach, the NT view, so it might be very nice in order to measure the nuchal, but due to the acoustic shadows that is reflected because of these bones, you can barely say anything about the midbrain hindbrain in a more detailed fashion. So how can we approach and how can we investigate further when we're suspecting that there is a problem in the posterior fossa? We should go for the posterior fontanelle, and if we insonate through the posterior fontanelle, what we come up is with a much better detailed image. And what do we see here? So we start from the mesencephalon going down to the rhombencephalon. The mesencephalon is the midbrain, and it is composed of the tectum here. The tectal plate is the posterior part or the dorsal part of the mesencephalon. The fluid filled aqueduct, and anterior or ventral to the aqueduct is the tectal plate, which is a little bit thicker than the tegmental plate, which is a bit thicker than the tectum. When you go down lower a little bit, you enter the pons with its typical pontine flexure, and below the pons is the medulla. Behind the pons and the medulla, you have the fluid-filled cavity of the fourth ventricle, as you all know, and if you're insonating correctly, the choroid plexus of the fourth ventricle will always appear as an echogenic bright spot or bar. It depends on how you look at it, and I'm sure you will be hearing much more about it from Professor Palladini later on today. You have to always remember that in this image, it looks like that there is a communication between the fourth ventricle and the cisterna magna, but this is a normal physiologic phenomena. We all know that the early description by Blake more than 100 years ago, and by Blake, and he described this normal evagination of the membrane into the cisterna magna before the vermis continues to develop, and once the vermis develops and becomes bigger, it occupies this area, and this foramina becomes smaller, and it remains as the foramina of Magendie. And this is how it looks on the specimen. Now, what about the vermis? And you see, I specifically did not write here the word vermis, although you're all expecting that below the aqueduct and above the fourth ventricle, along the midline, you should see a vermis, but remember that I prefer to call this structure at this stage just the future vermis and not actually the vermis. Another point for you to remember is that we have the two typical flexures, the mesencephalic flexure and the pontine flexure, which gives the typical appearance of the early midbrain hindbrain, the Z-shaped appearance, the Z-shaped kinking, which must disappear after 14 gestational weeks. Now, let's try to go through this in more detail and perform sectional anatomy. So the midbrain during the first trimester is, as I told you before, is composed of a very wide aqueduct and a thin tectum and the mesencephalic flexure, as you can see here, and this is how it looks on the ultrasound. So the upper cross section goes through here, through the midbrain and the tectum and the aqueduct of Sylvius. And when you go a little bit lower, you're crossing exactly through the upper cerebellum or lower midbrain, as you can see here, and the narrow part, the lowest part or the narrower part of the aqueduct as the isthmic area as it turns into the fourth ventricle and the upper segment of the cerebellar hemispheres spread up. Now, if we continue a little bit lower, rotating the probe, we cross exactly through the cerebellar hemispheres. You can almost And you can see here at this level, and also here on the insonation plane, this is exactly where the superior cerebellar peduncles cross. And as you all know, and you will hear about this later on, there are specific midbrain pathologies which involve the superior cerebellar peduncles. And if you go a little bit lower, you cross exactly through the choroid plexus of the fourth ventricle. And remember that this horizontal echogenic line is the fourth ventricle choroid plexus, and they curve into the two fissures on the lateral sides below the two hemispheres of the cerebellum. And so you remember that the fourth ventricle choroid plexus wraps around below the two hemispheres of the cerebellum into the foramina of Luschke on both sides. And then you scroll a little bit lower, crossing through the foramen, through the Blake's, normal Blake's evagination. So you can see here the communication. It's not a communication, it's a physiological communication between the fourth ventricle and the cisterna magna below the choroid plexus of the fourth ventricle. And this is a normal phenomena during late first trimester, what we call the neck of the Blake's pouch. And now if we look at the coronal images, it depends on where you perform your section. If you're cutting exactly through the cerebellar hemispheres, so you can see here that you're cutting through the aqueduct, as you see in the reference line here, and then on both sides are the midbrain, the walls of the midbrain, and then you go lower a little bit, so you see this hypoechoic structure, which are the cerebellar hemispheres with the beginning of the midline, the future vermis here in between, and below them, as I told you before, the choroid plexus of the fourth ventricle, as you will hear, I'm sure, from Professor Balladini more about that. And below that, you can see the opening of the Blake's pouch. And this is a normal physiological appearance, as you can see also here in the specimens. Now, if you go a little bit anteriorly with the coronal images, you fall into the lumen of the fourth ventricle, and at this section, you cross through the aqueduct, but more anteriorly, the upper part of the aqueduct where it funnels into the third ventricle. You see the entire lumen of the fourth ventricle. You see the choroid plexus on the way to the foramen of Luschke on both sides of the fourth ventricle below the hemispheres, and this is how it looks on the anatomic atlases. Now, what about the vermis? I have to say a few words about that, because there's a difference between looking at the vermis from the histological point of view under the microscope and under the ultrasound. The ultrasound is not a microscope. So how does the normal vermis look like at 12 gestational weeks? If you perform, and this is a very important work published in Science a few years ago that described the normal development of the human cerebellum and vermis. And if you see that at 12 gestational weeks, if you perform a mid-sagittal section through the specimen, you have a very smooth appearance of the cerebellum through the midline, and you cannot say for sure that this is about to become a vermis, because it does not have any characteristic or typical characteristics of a vermis, and this cut does not look different than if you cut through the cerebellar hemispheres. However, you see that already at 12 or 13 gestational weeks, towards 14 gestational weeks, the early primary and also the secondary fissures start to appear in the vermis, but they do not appear inside along the folio of the cerebellum. Still does not appear, which means that once you start to have a fissure, you will have reflections of the ultrasound. However, if you insonate, even if in the perpendicular approach on the cerebellum at 12 gestational weeks, you will come up with no reflections, so you will not have any characteristic image of a vermis at 12 or 11 weeks on the ultrasound, as opposed to what happens after 14 gestational weeks. So again, this is an image I showed you before. This is a normal fetus with a very high resolution imaging, and you put your dot on the midline where you are expecting to see the vermis, but you cannot really differentiate between this structure. You cannot say for sure that this is going to be a vermis. You just can say that this is the midline of the cerebellum. Now, how does it look on the live clip? You see here, this is a clip through the cerebellum, and you see there's a continuity of the echogenicity between the both hemispheres. And also when you rotate in 90 degrees and you perform a complete mid-sagittal cut, you see that the shape of this structure in the midline is not really different from the remaining of the hemisphere, as opposed to what happens later on in pregnancy when we insonate through the vermis. And sometimes we might have some extra additional fluid, and it depends on the angle and depends on the exactly gestational age. But you can see here also exactly that the cerebellar hemispheres goes from one way to another, and you cannot really say anything about the vermis. And also this, in this case, you see a completely normal vermis, but along the midline it becomes a little bit thin because the vermis is not yet to develop, but the choroid plexus below is continuous from one side to another. And in the midline, you know that in the future, the vermis is about to develop. And the last point for you to remember, as I mentioned before, that during 12 gestational weeks, the brainstem must have a Z-shaped characteristics due to these flexures. And this phenomena, I will talk about it later on in one of my talks, becomes straight after 14 gestational weeks. And if it does not, you should think of a pathology. So what is the take-home message from this talk? First of all, you have to remember that at late first trimester, the brain is still embryonic and many mature features and structures have not formed yet. So be careful when you diagnose abnormalities that usually appear later on. The lateral approach, as I showed you from the lateral approach of the skull, enables more views than just the classic axial one. So use it, rotate the probe in order to use this lateral approach for more images beyond the typical axial screening views. Whenever you suspect an abnormality on your screening, go for the transvaginal assessment. It will open a new world of imaging, a higher quality imaging. Try to manipulate the head as close as possible to the probe, as I showed you. Remember that the classic features of the choroid plexus versus the ganglionic eminence, because this sometimes might be tricky, and you may overlook or have a false diagnosis of various cystic structures, and I will talk about it later on. And remember that after 14 weeks, significant changes start to appear in the brain, which means that if you suspect a brain abnormality at 12 weeks, and if you're not sure, tell the patient to come back at 14, 15. Don't wait until 18 or 19 weeks. It's too late. Some of these malformations, and as I will show you, and also my colleagues will show you today,